But as Dr. Dravidhi is really coming in every meeting, actively participating in every meeting, and being so senior, his attendance is maximum. So I felt that no, sir, we should continue on it because his thought is his way of living, right. He's being active in every meeting of our conference, and in fact, me or Tom was there with him. We are just sharing the life thoughts, was lively, and Ramakar didn't join the banquet, but he was in the banquet, and he, on the stage, he was just like live, was very lively and share or share and everything, and whatsoever is sitting in front of him, उसके नाम पे शेयर पड़ा है, spontaneous. मेरे नाम पे पड़ा शेयर वहीं बनाया उन्होंने, जो बैठा था वहां पे सबके नाम पे शेयर बनाया. He was such a lively person, and we all feel that it should be what happens, and whatever happens, everybody will update you in our group. So with this, I feel that we should continue on this meeting, and maybe tribute to him also that okay, whatever happened to our members and all, we should go ahead. Whatever we are doing actually for actually betterment of each every Christian association. So with this, I welcome Dr. Meghna is presenting and presenting as a permit thermalism. Actually, just on the way, she'll be joining in a few minutes. So because the last moment changes, so we didn't keep a chairperson, but for this meeting, everybody is a chairperson. So we can have comments after this. Okay, Dr. Meghna, please.
Thank you, sir. Good afternoon, everyone. I'm Dr. Meghna Arora, DNBJR2 from Max Permanent. I'll be presenting an interesting case of pulmonary thromboembolism. So this patient came to our OPD. One second. This slide shown over there. So starting with the patient details, patient named ABC. Okay. So patient named ABC, age 36-year-old male who was an accountant in a private school and a resident of Delhi and Hindu by religion. He came with the chief complaints of shortness of breath since 2 months of initial presentation and dry cough since 2 months. So history of presenting illness, the patient was apparently normal 2 months back when he developed shortness of breath, which was insidious in onset and gradually progressive. Initially, he had breathlessness on climbing 1 to 2 flights of stairs. Slowly, it progressed to walking 100 meters on level ground. It was aggravated by exertion and relieved at rest. There was no relation with changes in posture, with no history suggestive of PND or any diurnal variation. Patient also complained of fatigue, which was not associated with any joint pains or dizziness. The patient also had cough, which was non-productive, insidious in onset, non-progressive, non-positional, and with no diurnal variation. There was no history of any chest pain, no history of fever, no history of orthopnea, PND, or cough with sputum, pinkish sputum, no history of wheeze or cough with expectoration, no history of syncope or presyncope. There was no history of any swelling of feet or pain in the right hypochondrium, and there was no history suggestive of atopy. There was no history of bluish discoloration of skin or mucous membranes, and there was no history of prolonged immobilization, travel, or recent surgeries. So, sorry? Smoker? Sir, in personal history, so he's not a smoker, but he was consuming 2 to 3 packs of tobacco per day, the small ones. Pouch. The pouch. So, past history, there is no similar complaint in the past. There was no history of asthma, COPD, type 2 DM, hypertension, or IHD. And there was no history of family history. Coming to personal history, his diet was mixed. His appetite was preserved. Bowel and bladder movements were normal and regular. Sleep was also undisturbed. So he consumed alcohol occasionally. By that, he meant 1 to 2 drinks in a month. And chewed tobacco, 2 to 3 small packets per day. But he stopped that a year ago. and he was not a known smoker. So coming to the examination, general physical examination, the 36-year-old male patient is moderately built and nourished, was conscious, cooperative, alert, and well oriented to time, place, and person. Vitals, the pulse was 110 beats per minute in the left radial artery, regular in rhythm, normal in volume and character. There was no radial or radiofemoral delay. There was no vessel wall thickening at all perimeters of mercury, and it was same in the left arm. Respiratory rate was 20 cycles per minute, and it was abdominothoracic. SpO2 was 95% at room air, and the JVP was raised. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. And coming to the systemic examination, cardiovascular system, on inspection, the chest shape was normal. Spine was central, there was no deformity. There were visible pulsations in the epigastric, and there was a left parasternal leaf. And there was no visible distended veins on chest or scars or sinuses. And on palpation, the findings of inspection were confirmed. Trachea was central. The parasternal heave could not be obliterated, so it was a grade 3 parasternal heave. And there were no thrills. And apex beat was in the left intercostal space, medial to the mid-clavicular line. And percussion was not performed. Auscultation on heart sounds, S1 was greater than S2 in the tricuspid and the mitral regions, and S1 was heard normally. S2, there was a loud P2 with no split in the pulmonary region. There was no additional heart sounds or opening snaps. There was a murmur, which was a pansystolic grade 5 blowing murmur, which was heard in the tricuspid region, best heard with the diaphragm of the stethoscope, which increased with inspiration and decreased with Valsalva and was non-radiating. So other systems, the respiratory system was normal. There were bilateral normal vesicular breath sounds, and there were no added sounds. Per abdomen was also normal. There was no organomegaly. CNS, his higher mental functions were normal, and there were no focal neurological deficits. So my provisional diagnosis after examination was that patient is NYHA grade 3 with symptoms and signs suggestive of right heart failure with TR and severe PAH. So investigation. So when the patient came to us, he already had a chest X-ray with him, and there was a small cavity in the left upper zone, and the rest of the lung parenchyma was normal. He was advised to get an HRCT because he was not in favor of contrast. So there was no parenchymal lesion seen, but there was a query thrombus in the pulmonary artery. So we admitted the patient, and there was, on ECG he had sinus tachycardia, and then CTPA was done with the DVT protocol. And on that, we had a large filling defect in the left main pulmonary artery extending into the lobar and segmental branches, more so in the lower lobe, and suggestive of pulmonary thromboembolism. Main pulmonary trunk and right pulmonary arteries and branches were normal in this one. And there was a small non-specific cavity in the left upper lobe anteriorly, which was also seen on the chest X-ray. And there was no evidence of DVT. And there was also a filling defect in the left renal vein, suggestive of thrombus. There was a video. I don't know why that's not loading. 1 second.
Do you have travel history?
No travel history, no surgeries, no immobilization history, nothing. So it was unprovoked.
No addictions.
Sir, tobacco. No IV drug abuse. There was a
moderately, but not very heavy.
no, sir. At this point, I would call him lean because since we've started the treatment, he's also lost some weight.
And what was his respiratory rate when he presented? It was normal.
When he presented, it was normal, sir. Over time, it increased. So we've been following him up for some time, and now it's around 30-35 every time. So when the first time he presented, we actually thought that the cavity was tuberculosis, and he was also investigated in. So reduced. No, sir. No fractures. The video is not working. It was the CTPA. I'm sorry. So the 2D echo, which was done on admission, had a heart rate of 108 with a dilated RA and RV. There was RV systolic dysfunction, and there was severe TR with RVSP of 75 mmHg. So there was PAH and there was TR, and some paradoxical septal motion with LVEF of 55%. There was no clots and vegetations, and there was no pericardial effusion. So we got some basic labs done. His HP was 10.9, TLC was normal, and platelet count was also normal. LFT was within normal range. There was no AG reversal, and KFT was also unremarkable. Excuse me. So we got his PT-INR. INR was 1.33. APTT was within the normal range. Protein C was normal. So we investigated him for causes of thrombophilia. And CRP was within range. D-dimer, as expected, was a little high. It was 833. Protein S was normal. Antithrombin 3 was normal. HBS, AG, anti-HCV, HIV 1 and 2 were all non-reactive. Lipid profile was within normal range, and HbA1c and TSH were also fine. So for the thrombophilia, we also got ANA done, which was negative. Lian vasculitis panel were also negative. Given that there was a cavity, we also thought of things like Wegener, and we got Pianka and Cianca done, which were also negative. Continuing with thrombophilia, factor V Leiden was negative. For APLA, we got antiphospholipid antibody IgG and IgM done, which were negative. Anticardiolipin, all three were negative. Lupus anticoagulant and the Viper venom test, all of them were negative. And HLA-B27 was also negative. But what we found was beta-2 glycoprotein, which is a criteria for APLS. The IgM and IgG are considered in the criteria, and IgM was equivocal. And given that it does not hold a lot of significance because it should be above the 99th percentile, but IgA, which is not in the criteria, was significantly raised. That was 46. So the tests were repeated after 12 weeks, and in the criteria also only in anti-beta-2 glycoprotein, it should be above 99 percentile on one or two more occasions, at least 12 weeks apart, and only IgM and IgG are considered, not IgA, which he had elevated. So we...
Was the Doppler done?
No, yes, sir. DVT doc was normal, was also normal. And in the course of this patient's disease, we also got a CCT abdomen done. So there was no any evidence of malignancy also anywhere. So course of the patient, a diagnosis of pulmonary thromboembolism was made, and the patient was started on LMWH for 2 weeks as bridging therapy for warfarin, because with the equivocal results, we thought of starting warfarin, 5 mg OD, which he took for a month, then developed a PR bleed at an INR, which therapeutic INR of 1.8, and was diagnosed with grade 1 hemorrhoids. At that point, he was managed conservatively, and we switched to apixaban. So he took apixaban 5 mg BD for 2 months. Then he developed another PR bleed, and he had an HB drop of 2 g%, and his HB went around 7.2. And following which he was operated for the same, and he was transfused 1 unit of PRBC. Then a CTPA was also done to look for the progression. I will discuss the CTPA next. And then he was discharged in that visit on rivaroxaban 20 mg OD. After that rivaroxaban, he took rivaroxaban for 2 weeks. He developed hemopsis, and we had to stop rivaroxaban. He had to be admitted again, and he was transfused again 1 unit. And he was discharged on apixaban 2.5 mg OD. That's all he can tolerate. And he's on regular follow-up with complaints of bilateral calf pains intermittently. And current medications are apixaban, along with 3 drugs for his PAH, that's ambrisantan 5 mg OD, Selexipag 200 mcg BD, and Biosigu at 5.5 mg BD. So the CT angio, which was done 2 months later, it showed the large filling defect in the LPA, extending into the lobar and segmental arteries, almost the same as before. But there was a new thing. There was another linear defect seen on one of the segmental branches of the pulmonary artery in the right lower lobe, which was not there previously. While he was on inadequate anticoagulants, but yet anticoagulants, and suggesting a partial thrombus. And there was a small caliber of superficial femoral vein, but no clots or thrombi were seen. So we repeated the 2D echo. The RA-RB was still dilated. There was no RB systolic dysfunction this time, but there was severe TR with an even more raised RBSP. It went from 75 to 80, and a paradoxical septal motion and an EF which reduced to 75%. 45%. So we further tested him. Factor V we had already done. So this time we got MTHFR gene mutation done, which was C677T. He had a homozygous mutation for that. So that is known to increase homocysteine levels. So his homocysteine was 62. So I did some research, I read some research papers, and according to that, the rise in homocysteine because of this mutation is not very significant. And they do not rationalize measuring, checking for this mutation anymore. And then we repeated the beta 2 glycoproteins, which were equivocal before, and it was still at 8.1, still below the positive cutoff, but beta 2 glycoprotein IgA was still high. So I found a few papers which showed that isolated IgA and 2 beta proteins could also be seen in patients with APS, and the presence of these bodies was found in 22% of patients with clinically APS who did not fit the criteria, and that positive titers should be considered. But the research on that is also very divided. While some people find a positive correlations, others don't. And we also got a COVID IgG done. So patient has no history of any COVID infection, but he received 3 doses of the vaccine. He received Covaxin, and his IgG values were 137. Covishield, sorry. His IgG values were 137, and which were pretty high, but not according to the values given by them. It's below the upper limit of normal. And then I found a paper which said that IgA anti-beta 2 glycoprotein 1, which was high in him, is a marker of increased thrombosis in patients with high COVID IgG values. So my final diagnosis was a middle-aged male patient with recurrent VT secondary to a hypercoagulable state, most likely etiology being a seronegative antiphospholipid syndrome, or second differential could be hyperhomocystinemia secondary to the MTHFR mutation, or as a consequence of COVID vaccine. We could not reach a definite diagnosis in this case.
How is he doing now? He's fine.
So we got another CTPA done. The clot is still there in the left side and still there in the renal vein, from the renal vein. And right now he is a little used to his dyspnea, still on 3 of those drugs for pH, and frequently gets episodes of hemopsis in between, so he has to discontinue his anticoagulants. Apart from that,
The patient seems that the pulmonary embolism has progressed.
yes, sir.
The heart failure has progressed.
Yes, sir.
He's not able to tolerate the wax.
No wax.
He uses MBR. So it does look like that we don't have a very clear-cut diagnosis in this patient. However, I think these 3 are possibilities,
Yes.
although he's APLA negative in all sense.
Yes, sir. But there were a lot of papers which said even if it's APL, the antibodies are negative, patient can still have seronegative APLS. So that's what we considered first, and we were thinking of treating him in those lines. But even at subtherapeutic INR, he was not able to tolerate warfarin.
This, I believe, the MTHFR mutation is an autosomal recessive mutation, right?
Yeah, yes, sir. But he is homozygous for it. Yes, homozygous.
What are the common signs?
For recurrent.
Which vessels are
So in antiphospholipid, if arterial circulation is involved, that is in the cerebral. Cerebral is more commonly involved. In the venous side, I found DVT along with the pulmonary. DVT is more common. That could lead to pulmonary embolism. That leads to pulmonary embolism. Along with that, splenic vein. So vital sinus. Yes, sir.
As the first, I welcome Dr. Nakshi, and just you will throw some light on this. Isha is already done.
Sorry for being late. I'm busy. Climbing stairs very fast. So thank you for giving us an opportunity to present our case. It's indeed a very tough and difficult diagnostic dilemma. There are 2-3 things. One is that patient does not have a patient presenting with a very stable pulmonary comorbidities. He was walking. He came with history of dry cough. We thought it is tuberculosis. वहाँ से drop किया, actually we lost the way. ऊपर direction में ना.
इसका क्या मतलब है? क्या मतलब है कि आपने बढ़िया टाइम
मैं कभी रास्ता देखती हूँ. I always think कभी मेरे driver change हो गया.
नहीं सही करते हो।
Very interesting.
It is other than interesting, it's a very difficult case. And patient has still been visiting us because he has been to all the cardiologists, cardiothoracic surgeon, hematologist, rheumatologist, and all big physicians, main physician. And he's come back to us. All the name like
Any family history in this?
like there is no family history. इसका कोविड का भी कोई हिस्ट्री नहीं है.
कोविड की भी हिस्ट्री नहीं है, सिर्फ वैक्सीनेशन के 3 है.
तो इसका सिर्फ 1 month का हिस्ट्री था, फीवर एंड नो फीवर, breathlessness and dry cough, and he came. I thought it was tuberculosis. छोटा सा cavity था, and there was some suggestion of pulmonary thromboembolism. We got a CTPA done, उसमें pulmonary thromboembolism आया. But patient was very stable. It was a big thrombus. RESP was high from initial beginning, but patient का room admission हुआ. I was stable to that extent. Surgeon ने देखा, he advised for surgical thrombectomy, but since patient was totally stable, although it was a large thrombus, so he said, I am fine. So surgery anyways hemodynamically stable था, तो हमने surgery advised. We started him on low molecular weight heparin. He became further stable. We checked whether it was tubercular cavity. It was not. Gene expert negative था. We thought कोई vaginous तो नहीं है, cavity है और थोड़ा thrombus है, या कोई infection तो नहीं है which has been disposed to thrombus, but there was no infection. And patient had no fever, no weight loss, nothing. Gradually, symptoms subside, and then put him on warfarin, and then discharge. Okay, patient was fine, kept him under follow-up, and thought he'll be fine. Came later, PR bleed hua, stabilized, then we discharged him on apixaban. Apixaban he was doing fine, and then he came back again with a PR bleed. Then we got a colonoscopy and a GI endoscopy done with a HP cross, and it was the cause of bleed was hemorrhoids. So we got hemorrhoid surgery done. Started him on rivaroxaban. So rivaroxaban he went home, and then came back again with hemoptysis. Then we do the CTP alone, and we found that thrombus has gone to the other side also. Despite being on rivaroxaban was in full dose. So the thrombus had gone to other side. So we again did a cardiac consultation and everything, but his RESP kept on rising. And despite being on rivaroxaban, hemoptysis gradually stopped, and there was no evidence of infection. There was no evidence of autoimmune disorder. ANA and everything was negative. एक बार ये beta-2 glycoprotein IgA was slightly positive, but he never fitted into APLS criteria. कभी कोई thrombosis नहीं हुआ. This was the only thrombosis episode. So we did not label him as APLS, and we continued. We thought DOACs are good enough for this, so we DOACs will continue. But फिर rivaroxaban से he had bleeding again, and we again put him on apixaban. So apixaban, he was taking 5 milligram weekly, which is recommended dose for pulmonary thromboembolism. But on apixaban 5 mg PD, again he had episode of hemoptysis and drop in HB of 2 gram. So we again put 2.5 BD. 2.5 BD. So अभी apixaban 2.5 OD पे है with no increase, and because his pulmonary artery pressures are rising gradually, thrombus का size भी थोड़ा बढ़ गया. We had put him on all the medication for pulmonary artery hypertension. But is to go again or
I'm just saying that like OD में selexipag is twice a day, and rivaroxaban is 0.5 mg. Tadalafil was not added because he has a BP around 90-70. So
थोड़ा postal hypertension. Patient is very stable throughout. He's doing his activity. वो अपना काम करता है, accountant का job है. He is very happy with himself and his family also very stable. It's just that the reports are not fine. So those three diagnostic and we want feedback from the house. One is, do we label him as APLS? Meghna, what do you say? Can we label him as APLS?
I mean, from all the research papers I've read, seronegative APLS to ban sakta hai, like
First episode of thrombosis,
From-
presentation first
for
episode,
the
based on this level of beta-2
glycoprotein IgA.
IgA, which is not even twice the normal. See, for any APLS, we say twice the normal.
Twice normal.
So this is just on a higher side of normal range. So with this, can you label him as APLS?
Just based on the IgM, which is equivocal, we can't. But there are a lot of papers which said seronegative clinical APLS can also be seen with negative antibodies. So that
We can label him as APLS, and APLS, the recommended treatment is warfarin.
warfarin and
We should
just
shift him again to warfarin. That's one thing. Secondly, MTHFR mutation and hyperhomocysteine, can it explain the thrombosis?
it can, and initially it was checked for that reason, but the newer research advises against even checking it because the homocysteine rise is not as significant with this certain
So
mutation.
hyperhomocysteine also you cannot label as a etiological
Yes,
diagnosis for the pulmonary
the embolism. Yes, not alone.
Third thing is, do you think COVID has something to play with COVID vaccination with an underlying hypercoagulous state? Because sometimes autoimmune disorder, initially we may not get all the picture which is there. Maybe another episode, or maybe we can label it as recurrent pulmonary thromboembolism and then label him as APLS. So these are 2-3 questions. And treatment wise, how should we proceed? IBC filter is plus minus, somebody says it, somebody does not say it. I haven't got it as yet. The question is on to me. And like, what do you feel and how should we proceed?
So I think basically it looks like. Okay, so treatment is.
So I think today we have taken 2 cases from diagnostic dilemma. So this one we will discuss the possible causes of it. So the diagnosis is certainly the way patient is having negative thrombosis, right? There is vascular issues are going on. So there could be a lot of different diagnosis, right? But overall, if you see that treatment would remain the same. You can't change the difference. Warfarin plus Noax could have a issue. So you say that in APLA, you have to switch over on warfarin. Otherwise, Noax are also patient probably would be on lifelong anti-COVID, right? That for sure. And we need to look into the CDPA. I think the 3 months or 6 month interval. The reason is the surgical part actually would come in place when you know that this clot is enlarging and we have high pulmonary artery pressure. So we need to take this CDVS surgeon opinion also that whether we would operate it or not because the last so it is progressive. That is my opinion.
Since it's fibros and there are old clots, the pulmonary artery hypertension may not get reversed even if we intervene. So what do we have to offer by removing the clot? Because clot the fibros clot and pulmonary artery hypertension.
Organized not leading to such a severe level of pulmonary artery hypertension. So because I don't think we have to do anything about the pulmonary artery. That's what she's saying, that the CTPS people feel that since the thrombus is organized, it's like diagnosed, it won't help using the
So what are we going to achieve? Like it's a chronic state.
There are 2 things that can be done. I believe that this patient is progressing for sure. And he's in fast deteriorating, fast deteriorating, but he's deteriorating. And he's likely to go into a stage where he might even collapse. So I would, in this case, not look at the distance analysis. I would increase the dose of your NOAX, put the IVC filter just to put him, give him a safeguard, and watch for the bleeding. Say we don't know where the embolism is coming from. So you are preventing further, episodes.
There is DVT. 3 times you've done CTPA. There is no DVT. The whole body So, could it be a primary pulmonary artery hypertension because patient stable है and उसमें thrombosis हो गया and this is giving rise because it's not DVT with recurrent.
He may not have a DVT. risk of developing APL is at risk of developing DVT. And he might throw a thrombus later on and or a bolus and he will die.
Good level in APLS.
No, I would not label him as an APLS because it's like a half-filled process, half-filled criteria. But given everything amongst these three, I would consider the first as the most probable.
Rather they have to change this.
APLS more.
Most of the time this APLS and this autoimmune normal, female predominance is always there.
Yes, sir.
Right? So 80% there, more than 80% predominance is there. So one diagnosis that come to mind is definitely is COVID, Covishield, and then there are come to Covishield and Covaxin. The Covishield cohort, actually the risk of thromboembolism are more. And there are a lot of papers also there which have been seen published in literature also. So there is one possibility. Homocysteine, I don't think so that it could be a reason, but yes, patient B plus the smoker, this tobacco chewer. So there are risk factors. So homocysteine plus smoking can lead to this problem. But definitely, this autoimmune I think we should take.
APLS should keep
Lower down.
It's probably with vaccine, a hypercholemic state, hyperhomocystinemia, and
Multifactorial level.
tobacco.
I mean, next we also have a patient like this is still evaluating around this age could get a pulmonary thromboembolism. So the homocysteine is in the borderline. Unfortunately, for us to get all the thrombophilia profile is a major challenge because RML में होता नहीं है. We send to AIMS, and sometimes they don't accept within the first 12 weeks. But yes, patient is old TB, he's got destroyed lung because of TB, and he also has an elevated RBSP. I think in but what I just said, he also has pulmonary thromboembolism.
So my thing is we have done thrombophilia panel without his being on oral antibiotic. Because
First presentation.
he present the नहीं because it was a chronic thing ना तो आपका आगे आपकी प्रेशर बने रहते हैं
खुद पे भी पड़ते हैं.
हाँ but बहुत ज़्यादा बने रहते हैं and patient was stable so indication of thrombolysis and thrombectomy are only when the patient is hemodynamic. Patient was totally stable, he did not know the relation. So only hemodynamic stability. Yes. But the patient
Organized.
yes.
First
First time is what was no 1 month history na.
So probably the episode I got there's one thing called catastrophic APL. Catastrophic APL is a very severe kind of presentation. And there's a possibility that the patient might one day have something like that.
What should have been positive now over the next
That's
3
coming
months.
up with it.
And I have sent to hematologists as well. Nobody has been able to label him as APLS. So we are also studying whether should we label him as APLS, try warfarin again. Because anyways, domains are not so we can try warfarin again or patient now doesn't want to.
I think we should continue with the picture.
No dose. Thrombus is increasing, pH is rising.
Increase the
Young patient and
Okay, fine, Jelly.
I sir, he bled once.
I only 1.8.
2.5 sir, he bled. 2.5 BDP also he bled.
and pH everything we can do to reduce pulmonary artery pressure. Postal hypertension बहुत ज़्यादा हो गया है काम नहीं कर पा रहा तो हमें हटाना पड़ता है so we are still working on it.
Very nice case.
Very nice case. Taking diabetes is two cases are difficult to tackle, and there are a lot of different diagnoses. So what comes out, I think it's a good thought, and definitely we actually are more wiser than we have this case.
Very nicely
worked out.
then.
I think Meghna has been after this patient chasing him and finding out the report.
So now I look at for Rajasthan sir to translate Nakshi and the black. concept. Yeah, good. आपकी जरूरत
Let me wear my glasses. Can we have the four of you together?
Yes.
What are we going to do? Where is the system? Come and look at it. Thank you. Yeah, good thing is that it's online. It's actually online.
Our next case is an interesting case of non-resolving ascites. The presenter is Dr. Lakshika Saini, third-year DNB resident, Max Vishali. The case was supposed to be moderated by Dr. Vandana Garg, but because of some family emergency, she is not able to join us here. Dr. Pankaj will be moderating this case. I request Dr. Lakshika to start with the presentation.
Thank you. I have already said that nothing to network here. We have not seen this game, but Vandana Garg has seen the game, but as sorry, yes, that he had some family tendencies to run the game. But definitely we have what would the policy that what that we've done now what we would so to solve the issue. And sometimes we are lost by in some cases. Despite everything, being in a corporate setting where everything is available from everything, still we can't make a diagnosis, right? So it's true with this case also. It's a difficult case and heads up the team that presentation is going fine despite of every issue, right? So this is a case of a young female post LCS and she developed what course that she had gone. She will tell us and definitely we will discuss that. What Lakshya is not interested is giving the theory examination and waiting for the practicals.
Good afternoon, everybody. Thanks for this opportunity. So today we are discussing a case of 36-year-old female which presented to us post LSCS. The indication for her LSCS was fetal bradycardia for her second pregnancy and who presented to the emergency with the chief complaints of high-grade fever since last 1 week, shortness of breath, more on lying down, swelling of both lower limbs, abdominal distension, and weakness. So her LSCS was done on 8th of October in an outside hospital and she developed fever around 2 to 3 days post-surgery, after which she was admitted in our hospital on 21st of October with above mentioned complaints. And she's a known case of hypothyroidism. So at the time of admission, her labs were TLC was 23,000 and CRP was 304. On examination, she had no paler icterus, cyanosis, clubbing, lymphadenopathy. She had bilateral basal crests and reduced air entry in lower zones. Chest was normal. CVS examination was normal. Her abdomen was distended, though soft. She had bilateral pitting edema. JVP was not elevated. She had SpO2 of 90% at room air. Her X-ray was done, which showed diffuse haziness noted in both lower zones with obscure diaphragm. Ultrasound abdomen showed hepatomegaly with grade 1 fatty liver, gallbladder sludge, and moderate ascites. Up till here, our first diagnosis was peripartum cardiomyopathy, but then we got an echo done, which was absolutely normal. So that was ruled out. Then we moved ahead with CT abdomen and thorax, which showed bilateral pleural effusion with atelectasis, and abdomen showed hepatomegaly with moderate ascites, diffuse peritoneal thickening. Portal vein was prominent, and there was a collection, hypotense collection near the right rectus muscle. abdominal strictus. So in view of the collection that we got in the CT, in view of the moderate ascites and the collection that we got in the CT, a USG guided ascitic tapping was done and by the interventional radiology team, which was suggestive of low SAG ascites. So the final reports were cytology was negative, gene expert was negative, ATA was 33.1, which is borderline for tubercular, so not very definitive of TB. LDH was raised and TLC count was raised, is what that was 1600. It was neutrophil, so again not in a favor of tubercular, and glucose protein, it was low SAG ascites. So, and also during the cultural sensitivity, we got two very resistant MDR bacteria, which was Klebsiella and Pseudomonas, which was only intermediately sensitive to polymyxin and colistin, and none other antibiotics. There were AFB culture, AFB stain was negative, fungal examination, gram stain was normal. So DDs considered up till then was peripartum cardiomyopathy, ureteric injury because of low SAG ascites, bowel leak, and tubercular peritonitis. So in view of the persistent distension and ascitic tapping also, there was again the abdomen was getting, there was persistent this urology opinion was taken in view of query ureteric injury also. So they sent a fluid, urea and fluid creatinine values, so which was again normal. So there was not suggestive of any ureteric injury, and ureteric injury was not even shown in the CECT abdomen. So that was ruled out. And again, we got a review from the IR team to put a PCD drain because of the reaccumulation of the fluid. So they said that there are severe internal septations and they are not able to drain the fluid completely. They will only be able to drain the fluid from that one pocket in which the PCD drain will be put. So that's another obstacle because her fluid is not able to be drained and it has two MDR bacteria inside. So gastroenterology consult was taken and they also suggested as a possibility for septolysis because antibiotics was not able to reach the bacteria due to septations and we were not able to drain the fluid due to septations. So no, sir, because that then only we got to know that there are septations. When they were ultrasound, se unhone dekha that there are septations. So it didn't come up on CT. CT we got on the second day, the very first day she presented, it was not reported in the CT.
CT was done.
No, CT was done earlier. It did not show septations. We got the ascitic fluid tapping done, the fluid reaccumulated. Then we sent the patient for a pigtail insertion. Then the IR team did the ultrasound and they said that there are severe septations. We won't be able to drain the entire fluid. We will be able to drain only the pocket.
So that's what CT did not show septations.
Yeah.
The IR team, when they did the ultrasound later on, they found septations.
They found septations. So a gastro consult was done. They raised a possibility of septolysis by the injection streptokinase. But then again, as we discussed with the OBGYN team also, the suture line was very fresh. So there were chances of bleeding. So that option was scraped. Now again, we got a consult from oncosurgery team, which also suggested CCT whole abdomen with oral, positive oral and IV contrast, because if there is a bowel leak, which is the source of again and again accumulation of that, then we'll have to go for urgent.
So the patient.
Sir, actually, we were not able to find any source of the reaccumulation of fluid.
So how fast was the reaccumulation?
Sir, we drained her on first day, 1800 ml.
1800 per day one.
Day one. And then on like third day, it was moderate ascites again. Yeah, on ultrasound. Sir, she was on oxygen. She was on oxygen support throughout, like nasal prongs 4 liters, 3 liters, 4 liters. We were doing the abdominal girth charting, sir, and it was increasing.
So I think they got
So just to find the source of reaccumulation of fluid, we did the CT with positive contrast this time, positive oral and IV, but there was no leak, no bowel injury, no ureteric injury. So again, we decided for putting the patient on conservative management for again 24 to 48 hours on antibiotics. These are her labs so far.
We have seen information.
Sorry, can you go back?
So
We have seen very common. We have seen fluid diffusion, suppose the government that is or fluid is diffusion and again it but no, acidic fluid refluid so far. If you know the primary what is there, what is the that is what we have found out. So that is not the treatment that we are taking it out.
we are trying to reach the primary pathology only, sir. That is where.
Yes.
So these have been her labs throughout. Her TLC count when she arrived was 23,000. Now it has come down to 11, 12, 13,000. It's fluctuating amongst that.
She's on cholesterol.
Sir, I will show that. Right now, she is not on any antibiotics considering drug fever. I'll show that chart also. So this is, and her procal has been more or less very stable. CRP was high initially, but now also again 122, 148, 116. NT-proBNP is fine again. Echo was normal. And then we also went ahead with some atypical infections for test for Leptospira brucella. Everything was normal.
Yep.
Sir, albumin was more or less like 3.1, 3.2, 2.9. We corrected the albumin also, but that didn't subside.
That is low side.
That is a low sarcocytis, sir. It's not the cause, yes. And her creatinine has been somehow very normal. KFT is normal all throughout. So we have done few cultures for her. All the while her blood cultures have been sterile, but her urine cultures showed candida. Her vaginal swab culture again showed two very MDR organisms, Enterococcus and Klebsiella. CBP line culture was sterile. Sir, in an outside hospital in Ghaziabad region only, but like a small. Yes, sir. Two sides, sir. High vaginal swab. She was complaining of vaginal discharge, which we initially thought it's post-surgery, post-delivery, but yes, sir. We again went ahead with some atypical infections because her fever is not subsiding. She has been on high-end antibiotics, persistent high-grade fever, even on 8th hourly PCM, 8th hourly meftalfort, her fever is not subsiding. Again, all the atypical infections also came out to be negative. This has been her treatment since the time she has been admitted. First of all, we started on her sub-DT and metro on the day of admission. Then we changed to imipenem and cilastatin on the next day. Her TLC count was 23,000. As per the ascitic culture report, Klebsiella and Pseudomonas that we got, we started her on mirobactam and colistin. Her fever was not again subsiding. Then we discussed it with our microbiologist, and she suggested that the synergy effect of Zyvicept and Astronam infusion will be sensitive. Even if the individual drugs are resistant, the synergy in infusion will be helpful. So we started the infusion of Zyvicept and Astronam. Her fever was not subsiding, not responding. We gave her a trial of anti-malarial drugs too. Voriconazole, as per the culture sensitivity reports, again, she was on tigecycline as per the vaginal cultural sensitivity reports. Levofloxacin empirically started, and her abdomen is still distended. Now it showed thin, severe internal septations with mild bilateral pleural effusion. IR team again could not put a drain because of the severe septations. We have put her on injection clindamycin for an anaerobic cover. In view of prolonged and non-responsive fever, they got a second opinion from Maulana Azad Medical College from one of their relatives that we should start her on ATT. Then we got a consult with our gastro team, surgical onco team, and internal medicine team. We have no objective evidence of tubercular anywhere right now. So the decision of ATT was put on hold for now. And in view of rising inflammatory markers, see, procal is normal, TLC is fluctuating around 10,000. So we were also of the opinion that this fever is inflammatory. So that is why we have put her on anti-inflammatories also, antipyretics, injection paracetamol 8th hourly, Maftal 8th hourly. Right now, all her IV and oral antibiotics have been stopped considering a possibility of drug fever. She is on only antipyretics 8th hourly. Still, she's running fever every 6th hourly, 8th hourly, 100, 100.2, 102, like that. And her abdomen is still distended. She's not able to take a full meal because she feels nausea. Her abdomen is distended and she right now as well.
So day 8 of fever or day 10 of
So day though it's like more than 30. She got admitted on 21st October. 21st October. 8th of October ko illness. Uske third day se she's having fever. She's having fever till today. I just took her around. She had 102 fever today. And right now our dilemma is
Right. I think it's a case that you would want to discuss.
yes.
What would be your opinion? Because patient having fever and for almost 1 month, in this CS7, 8, and now it's well, and say the patient has fever, say the patient having more extension of coming. So I think I was not part team, but just one that discuss the team. This was very much. If I listen to we all 6 of us sit together and the take opinion, right? And I think right, because sometimes we are missing. So the attendance have directed to start beginning on right? Area of 31 and high sub I think there's no indication for starting immediately. So the first point is whether we should start it or not in particular case, because all everybody has been stopped. The ECT program is normal, right? It's not patient not it's flu signs, it's not from fever and the internal suppression are there. So the number 1 point, what next, what antibiotic was seen, we have exhausted everything. All the antibiotics except and then cholesterol, everything else. Antibiotics is not criteria number 1. Number 2, we should start eating or not. So we should make concept.
And the third call is we should.
Third call is protein accordingly. I was in favor of because when I discussed again, I saw if you are not finding because you have to go for protein accordingly. To take out all the biopsy. This thing can take a biopsy, it's not only an issue. Right, to make a diagnosis.
We are hesitant to start eating, rightly so, because there is no conclusive evidence of so we have to
Comes what you have positive.
if we don't find any evidence, then I think we'll have to somehow.
So there's a point of
See the whole history, it's all post LSCs.
Yeah.
Absolutely.
So the chances of it's very less post LSCs patients having all these problems.
So that is sometimes patient have direct glucose because
That is exclusive criteria.
You say compensation and patient getting glucose and then it may come up. So glucose cannot go on at this moment we do not have concrete evidence of glucose, but we have suggested to go for. I think today is a meeting was cancelled because of we have an underboard with all the faculty setting and we discuss to go for it, but because the only thing you have to know as of now.
When you start eating, stop. Because you have to wait for it. So for the next 2 weeks or 3 weeks, you can't do it. So before making that call, if we are not taking anywhere because all this should be discussed, we wants to go to 100 games
Yes, sir. For 82.
or start away eating. So we said that so we said that if you want to eating, just go to the doctor. So whatever, but in our opinion, that we should your product should be done.
So the second school of thought of the surgeons that we are consulting every day, they are saying that it is not an infective fever, it is just inflammation. So the surgery, we are putting her at a risk of a very invasive surgery because we might have to turn the laparoscopic surgery into open because she's having severe internal septation. She might go to ventilator. Right now, she's just having fever. Later on, you might be dealing with a patient on ventilator.
if we don't find the cause, patient ultimately will get it's on basis.
No, on one hand, we are saying it is not on.
No. We had
One hand, we are saying.
No.
How will you come to know? We have.
Yeah, so no, we had not audited certain right?
Yeah, MDR.
Issue is that having MDR.
That means it is somewhere hospital required. He had in the earlier hospital.
The instrumentation could have been, yes, infected, absolutely. This is normal, procal is normal, and the inflammatory markers are raised.
Wherever she got the LSE is done. Probably not the most hygienic place to get the LSE is done. That's when everything got introduced, and then these are the consequences of that. Explorative laboratory completely agree with the surgeon that this is going to be a very high risk case.
Absolutely.
They will not touch this case.
They are not ready.
So I think
Now we are in the dilemma, like what to do for her fever.
try antibiotics which are probably lower down the order and not really higher. For example, trimethoprim Exceptron and things like that, or doxycycline. But I don't know, we are at a dead end at this point.
Absolutely, we are on a dead end.
Yeah,
But so if she has not responded to Zyvocepta Astronam, will she respond to a antibiotic?
see, you given
Cultural sensitive, not sensitive, yeah. Anti-malarial.
Antibiotics. There's nothing left for us to give except for the lower ones.
I think with this, definitely anything comes up, we'll discuss the
Keep us posted. Keep us posted.
Thank you, Dr. Lakshika. Very nice presentation. I think on the call.
I request Dr. Mark to kindly felicitate Lakshmi.
I hand over this contact protocol now. So with this, we conclude this session, and now the best part of it, the announcements of the champion award. The award that they are giving me the champion award every month. So this time, the champion award has been conferred to none other than Dr. Ninadan. Dr. Ninadan, we all know him, we all know his father, who was a great philosopher, author, and everything. So I think I request our scientific co-chair in this, your scientist, co-chair of this incoming honor, sir.
Sustainable development, resilience of tourism was inspired by
So I will study to get from the back. Production is on the back. The back. Very good. Thank you. I wanted to say next meeting on the slide. Right here. ऐसे अच्छे इसको ऑफ करो राइट ऑफ करो
I wish to thank